So today I'm going to give you a lecture on scrotal ultrasound. We'll talk about the anatomy and some of the pathology that you may see with scrotal scanning. Um, so the most common cause for a scrotal ultrasound being performed is, of course, the investigation of acute scrotal pain, which includes scrotal trauma. We will also do a scrotal ultrasound for evaluation of swelling or masses, and I'll go over a few of the more common incidental findings that we may see with ultrasound of the scrotum. So we'll start with a few questions. So just to think about during our lecture today, and hopefully you come up with the answers as we either maybe now or as we progress. So this is a 22-year-old male who presents with a straddle injury and acute scrotal pain. So this is an ultrasound of the affected testis. So the question on this slide is, what are some of the potential complications of a testicular rupture? So could it be an AVM? Is it infertility, testicular infarct, or all of these? Okay, this is another question. So you can see there's the testis here. This is a lesion. The lesion depicted on the slide is it has a statement. So the lesion on the right here is most likely a malignant lesion. So is this a true statement? Is it false? Or are we unable to determine because we need to have more information about the patient and his age? Okay. So here is another question. So this is a 4-year-old male with a testicular ultrasound with painless scrotal swelling. What is the diagnosis? So is this a varicocele? Is this a cystic mass with a mural nodule? Is this an epididymal head cyst? Or is this a hydrocele? And finally, this is a 25-year-old male with a scrotal ultrasound. This is what you see there. So what is the diagnosis? Is this a testicular abscess, testicular torsion with infarct, testicular microlithiasis, or is this all seminoma on a background of testicular microlithiasis? Okay, so before we get to the pathology, we'll talk about the anatomy and technique of scanning the scrotum. So normal scrotal anatomy.
I'm so sorry to interrupt. Will it be possible for you to give me permission to record, please?
Oh, I think Omega is already recording, but yes, absolutely. I didn't see that
Thank you.
I didn't see that you were online. I'll get you as a co-host too. There we go.
Thank you.
You're welcome. And I'll send the slide over to both of you today so that you can share it. Okay. So scrotal anatomy. So the scrotum is in the sac, of course, that extends from the spermatic cord. It contains the spermatic cord, of course, contains the vas deferens, the pemphidiform venous plexus, and of course the vessels there. We also have the cremasteric muscle that surrounds as part of the layers of the spermatic cord, and then of course here at the very bottom of that we have the layers of the cord. We have the tunica vaginalis that surrounds the testis, and then of course the investing layer of the tunica vaginalis, the visceral layer, and then we have the epididymis, and of course it makes a U-turn here with the vas deferens. So just a close-up of that. Here's the vas, makes a little corner here. This is the tail of the epididymis. This structure here is the epididymis. There's sometimes a small little nubbin at the top of the head of the epididymis called the appendix epididymis. And then, of course, you have your testis. There's a potential space between them. There's your cremasteric muscle. This is your tunica vaginalis, and this is the visceral layer of the tunica. And then very closely applied to the tunica vaginalis is the tunica albuginea. And then here's your actual testis that is separated by these fibrous strands. So just keep that anatomy in mind while you're scanning because it will become useful. Okay, so the vascular supply. Just note that the testicular artery um, is derived from the internal iliac, sorry, not derived from the internal iliac artery. It comes straight off of the aorta. And what you also need to note here is that the venous drainage is different between the left and right, in such that the testicular vein drains directly, so on the right side, directly into the IVC, whereas the left testicular vein actually drains into the left renal vein before drainage into the IVC. So the lymphatic, so this is a reason for the varicocele to be more common on the left side, just because of the more long course of venous drainage on that left side. Lymphatic drainage follows the venous drainage, so we drain up into the internal iliac veins, and of course, it makes sense that the paracaval and the para-aortic lymph nodes here are the usual first sites of lymphatic metastatic disease in the setting of testicular malignancy. So when we do CTs in that case, that's where we're closely looking because that's often the site where we see lymph node metastases. Okay, embryology, always a confusing topic because there's so much going on, but it's important in the case of the testis to understand how it descends appropriately into the hemiscrotum. So the testis begins in the intra-abdominal, of course, and it is pulled down into its normal position by the gubernaculum, right? So eventually, the gubernaculum, along with the processus vaginalis, extends down into the scrotal sac here. So the processus vaginalis in the early embryologic period is communicates directly with the peritoneal cavity. Eventually, in the adult form, this communication is sealed, and that is obliterated. But as you know, in this, you can sometimes still see some residual fluid, especially in babies in the early neonatal period. Because of the residual fluid from the peritoneum, so you can see these scrotal hydroceles in babies. So the layers of the tunica vaginalis actually used to be the layers of the peritoneal cavity there, and then the gubernaculum, which pulls the testis down into the scrotum, it becomes just a remnant at the end there. So okay, so what does a normal testis ultrasound look like? So first of all, we want to be scanning these with the highest frequency transducer that we have. We use a linear transducer somewhere in the range of 11 to 15 megahertz. So because it's such a superficial structure, we are able to evaluate the testis in very great detail with the high frequency transducers. We don't need to worry as much about having to penetrate the testis because it is such a superficial structure. So we want the highest transducer, or sorry, highest frequency transducer as we have. So here are representative images of a normal testis. Here's the right and left testis side by side. This is the scrotal wall here. Again, this is the testis. You can actually even see the tunica vaginalis and tunica albuginea layer here. There's a very thin echogenic line. And then, of course, on the opposite side is the parietal layer of the tunica vaginalis. So the average adult testicular size is somewhere around 3 by 3 by 3, sorry, 3 by 3 by 5 centimeters. They're usually symmetric, give or take. So here's a normal adult patient. You can compare the sizes just even subjectively, right? Here's an adult testis. Here is an adult patient with Klinefelter syndrome. You can see here the testis is much smaller. It's 1.1 and 2.5 centimeters. So the sagittal length of this is about half of what we expect. So this is of course a testicular atrophy in someone who's or just it just never developed fully into an adult male size. Okay, so part of the normal spectrum again. Um, you can see in when you scan, you see this, depending on where your probe is relative to this mediastinum testis, you see this coalescence of echogenic tissue that looks like in a line, a band here, um, peripherally in the testis. So this is just the coalescence of the dense fibers of the tunica albuginea as it inserts into the testis. And I'll if I just remind you here, so it's right in here, right? You can see this is the tunica that it invests into the testis. So that's what this, oops, this structure is. So not to be mistaken for pathology. Okay, so the reti testis, right? You have the vas deferens, then the you extend into the epididymis there, and then this structure here, again on the eccentric side of the testis, medial side of the testis. This is your reti testis. So these are composed of all of these multiple little tubules, and sometimes you can see this as a structure that's similar to this. In the setting of a prior vasectomy, prior infectious processes, sometimes the reti testis, these little ducts can become distended and have a almost cystic ectasia appearance. So I probably have an example of that later, like right there. So the tubules get dilated, and you get these cystic changes. So this is the same structure as this, which is normal, which is represented here in this diagram, except in this case, perhaps the patient had a vasectomy in the past. The ducts or the ductules get quite dilated and cystic looking. So this is not, you have to evaluate and determine, is this location consistent with the reti testis? Okay. We'll move on to the epididymis. This structure here, almost similar in echotexture as the testis. You can see it is a separate structure, superior to the testis. So this structure here, it represents a portion of the epididymis, likely the epididymal head by position. So just a reminder, the vas deferens here enters the tail of the epididymis, and then as it ascends, the head of the epididymis becomes thicker and more bulky, and then it invests into the testis, and there are the septa and the seminiferous tubules. So, so this is the head, this is the body and tail of the epididymis. The appendix epididymis is intimate to the head of the epididymis. So usually we don't see that because it blends into the head of the epididymis. Sometimes we can see it as a little outpouching if there's a lot of fluid, or in the setting of pathology if there is a torsion of the appendix epididymis. Okay. So the appendix epididymis, I mention it because sometimes it can be associated with pathology. It's this little outpouching, and it's a remnant of the mesonephric duct system. So I found this online. This is the head of the epididymis here, and then there's this little structure right next to it, separated by an echogenic fibrous band that represents the appendix epididymis. We don't usually see this normally. Typically, if you imagine, if this fibrous band wasn't there, it would just blend all into one structure because of the echo texture being so similar. Okay, the tunica. So tunica vaginalis and tunica albuginea, you can see this very thin echogenic line here. Actually, this is a double echogenic line. That's the lining of the testis and the tunica, the visceral layer of the tunica vaginalis and the tunica albuginea. So it's just a fibrous capsule that surrounds the testis. Okay, so we talked about the epididymis testis. There is also an appendix testis, which is in a different location. So it is a focal expansion of the tunica. So it is attached to the outside capsular margin of the testis. So unlike the appendix epididymis, which is attached to the head of the epididymis, the appendix testis is attached to the testis itself. So it's a remnant of the Mullerian system, the paramesonephric ducts, rather than the mesonephric duct system of the appendix testis. We don't always see it, but sometimes we do, and this is what it looks like if it's seen with some hydrocele fluid around it. Okay, so the technique for scanning. First, if the patient is showing up with testicular pain, and the purpose of the exam is to evaluate for pain, we want to start the scan on the patient's unaffected side because we don't want to start with the most painful side first. We want to just get an idea of what the background testicular equitexture for this patient looks like, what is the side, the unaffected side, the size and vascularity look like. So you want to do two imaging planes, in the transverse and sagittal. You can also do a comparison image, and then you want to sweep through in the entire testis and the scrotal content, so the testis, the epididymis, and the cord itself. We use Doppler quite liberally with testicular ultrasound, especially when we are suspecting torsion or if there is, unexplained scrotal pain. So for those who haven't done a lot of ultrasound, we have basically three types of ultrasound capability in most of the machines. So depending on which buttons you push, you may have different results. So the first one, the most common one that we use is color Doppler. So that's when we press the color Doppler button, the image map that shows vascular pulsations will get a color map assigned to it. So red or blue or shades in between. Blue indicates that the blood flow is away from the transducer, and red indicates that the blood flow is towards the transducer. So the color gives you an idea of flow direction and also an idea of sort of how much flow there is. We also, when we are looking for something that has very slow or very small amount of flow, perhaps very small vascular structures, we use something called power Doppler. So it's a different button. This one doesn't give you a color map. It is just, it's kind of, most of the time the map is colored in an orange if there is flow. So it's very sensitive to flow, but it doesn't give you directional information. And then, of course, there is a pulse Doppler where we actually have to actively put a gate over the site of concern, and then we look for, and it gives you pulsations, and we look for that arterial flow and venous flow in the testis. So we use all three of these if we can. Okay, so here's an example of, this is a color map, first of all. So this is color Doppler that shows some arterial flow and some venous flow here and some paratesticular flow. So all of this stuff is, the color stuff is inside the testis, so you can see that there is flow. And then here is pulse Doppler gate that we put. So right now we're sampling in this little set of pixels, and it gives us live this pulsatile waveform. So this is an example of a low resistance arterial pulsatile waveform. You know, there's a systolic peak and a very long diastolic component. Okay, so we'll move on and talk about the investigation of acute scrotal pain. So what is why do we scan the testis? Well, what we're worried about, of course, in the setting of an unexplained testicular pain, one of the potential causes can be testicular torsion. So, some people have this bell clapper deformity of the testis that can predispose them to having testicular torsion, where the testis rotates on the cord. So up to 12% of males have this higher insertion of the tunica vaginalis that allows for this torsion. So most of the time the tunica inserts quite low here, but in some patients the tunica vaginalis inserts higher on the spermatic cord, which allows more room here for it to twist inside of the scrotal sac. So um, in the setting of this bell clapper deformity that can occur in 12% of male, some of them are bilateral in up to 40% of those cases. So it will obstruct the testicular artery flow, which can cause, of course, ischemia, which may be irreversible. So we're very cognizant of the timing of 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 how much or when the scrotal pain started before we scan, because timing is important in trying to salvage the testis. So if we are able to intervene within 6 hours of onset, you have 90 to 100% viability of the affected testis. Um, if we delay diagnosis by another 6 hours, so if we wait until 12 hours from the onset of symptoms, that salvage, it drops to 50%. And of course, when the further out from the onset of symptoms, the less likely we are able to salvage that testis. So by 24 hours, there's usually no chance of salvage. So it's crucial that we intervene and diagnose this as early as possible. So tips for scanning testicular torsion. We want to use power Doppler if we are unable to find color flow. So we'll start with color Doppler with the blue and the red, but if we don't see any obvious flow in that modality, we will switch to power Doppler. So it's very useful, especially in kids, because kids, I find it's harder to get color flow seen with the small testes of children. It just doesn't pick it up. So power Doppler is useful. Another hint is use power Doppler and then you increase the gain. So you increase the sensitivity until all you see is, just it fills in the color map, and then you slowly back off on it until all you see is some pulsatility. So you don't just turn on the color Doppler, because if you just turn it on and then look, sometimes movement and even breathing, some things will actually fill in the color map with an artifact. That's not true color flow. So what you need to do is hold it still, turn up the gains until you see some what we call flash, where it's just kind of flashing on the screen, and then you decrease that gain, and then you wait, and then you look for structures that have a color flow map but are pulsatile, regularly pulsatile. That's when you know that there's flow there. Um, we use pulse Doppler. That's a more advanced technique, but is also useful for us. We can see this preservation of those arterial waveforms when there is an torsion and detorsion component to this pain, or if the torsion is still very early. You can still see before the arterial system is compromised, you may still be able to see some arterial flow. So the first the first vascular compromise is actually venous outflow. So if in the very early torsion, we can still see arterial flow, but venous flow is obstructed. So we have to be careful there. And we may notice that in detorsion, you can actually increase the blood flow to the affected testis. So we have to be cognizant of the history and do serial ultrasound sometimes to recognize that that is a possibility, is that the pain was acute when it was torted, and then it spontaneously detorted, pain reduces, suddenly there's hyperemia on Doppler, and then that sequence again starts anew. And so we have to scan during the patient's most acute symptoms if possible. Okay, so here's an example of a torsion. So here's the right testis, here's the left testis. We have set the color bar, or the how much color flow we see at the same for each. Here's the left. You can see quite easily there's both arterial and venous flow inside the testis as well as adjacent to the testis. On the right side, however, there's no internal flow at all. This little dot here is actually on the periphery outside of the testis. If you also compare between the two, this has, that gray echo texture that we saw earlier. Um, However, on this right side, the echo texture is a little more hypo, right? It's darker, and it's darker because of edema. So both of those things. This is a right testicular torsion. Okay, here's another example of torsion. We are using a color box here. There's absolutely no flow anywhere in this color box. And then you can actually see these little hypoechoic striations, right, in the testis. So this represents testicular edema that is kind of following those fibrous septa within the testes, within the testis. So there's edema, and then of course you can see this little anechoic component here outside of the testis, which represents a hydrocele. That's an incidental finding. Um, that may not be related. So here's another example of torsion. So this color box is larger than the testis. You can see there is color here, but this is all outside of the testis, and there's no detectable flow within the testis, which also looks hypoechoic and edematous. And this blood flow on the outside is increased, greater than we would expect, just because it's trying to compensate for the arterial torsion and ischemia of this testis. Of course, there is no accessory blood flow um, from the other vessels. So the sole supply for the testis is that testicular artery within the spermatic cord. Okay, so sometimes when you scan, um, you can actually see the twisted cord above the testis. So it's called a whirlpool sign. So basically, you just see these concentric rings. This is the representation of that twisted spermatic cord sitting right above that testis. Okay. Other causes of scrotal pain. Um, is that we spoke earlier about the appendix testis. Sometimes this appendix testis can tort. So not the whole testis, but just that little appendage next to the testis can rotate. It's typically seen in the setting of pediatric patients. There's this, if we were to scan, there's this hypoechoic nodule that's attached to the testis that is quite painful. And clinically, you see what's called the blue dot sign, which represents the um, the torted appendix testis. So this can cause pain, but is not a testicular torsion, and so not treated in the same manner. Okay. So what are the other causes, potential causes of scrotal pain? In the adult, I would say this is the most common thing that I see as a cause for scrotal pain once we rule out the possibility of a torsion. So usually the cause of epididymoorchitis is retrograde spread of bacteria from either the bladder or prostate. So it can be, sexually transmitted, such as gonorrhea or chlamydia, but depending on um, the root and cause. The enteric bacteria, of course, especially in the elderly, can have a cause of epididymitis as well. So what happens, of course, is the bacteria ascend along the vas deferens, and then the first site that they run into, of course, is the tail of the epididymis. So usually it's a sequence. So it starts in the epididymis, often in the tail, because that's the first site where the bugs encounter um, resistance, so to speak. And then it will move into the rest of the epididymis and then finally into the testis. So you can have epididymitis alone, which is most often what I see. You can, as it gets worse, you can have epididymis and the testis. So you can have the epididymo-orchitis sequence, and then of course you can isolate to the testis alone, which is orchitis. And if you inflame the entire spermatic cord, that's called funiculitis. Okay, so what do you look for? Like anything that's any inflammatory process, edema, inflammation, so thickening, heterogeneity, hypoechoic appearance, and then of course increased vascularity on Doppler. So it's nice because you can compare sides if you're not sure. And I'll show you some examples here. So here's an example of the grayscale image. This is the testis here, and then right next to the testis, you see this enlarged, heterogeneous looking structure, which represents the tail of the epididymis. And when you put color Doppler on it, this just lights up with hyperemia. So this is acute epididymitis of the tail of the epididymis. Here's another example. This is the tail of the epididymis again, lots of vascularity. There's edema and thickening. Okay, here's another example. Here is the testis. So, you see that uniform echo texture. And then this very thickened heterogeneous structure adjacent, which represents the epididymis. You can see how vascular that is when you put color Doppler on it. But that vascularity also extends into the adjacent testis. This is also hypervascular. So this is an example of epididymo-orchitis. Okay. This one, if you were just to look at this, as a grayscale, you may be wondering, okay, well, what's happening here? Is this a traumatic episode? Is this a testicular rupture? But in this case, the patient had acute pain and symptoms consistent with orchitis. You can see the testis doesn't have that, uniform grayscale echo texture, but you see these kind of, linear lines there. It almost looks like a zebra skin or a zebra, where what happens here is actually this is edema of the testis. And so because the fluid tracks along those fibrous septae, they have this kind of alternating, gray and then darker lines. So this is an example of orchitis. So remember, I can review, we can compare side by side. So the patient obviously would have had symptoms on the right side. We put color Doppler over the right and left testis at the same time. This is normal blood flow here. You can see how much more blood flow there is on the right side. So this is a right orchitis. Okay. Complications from orchitis if it's untreated. The testis here is surrounded by all of this multiseptated fluid collection within that potential space that we would normally see a hydrocele in. So in this setting, because we know, this patient has acute pain and didn't have trauma, this is an orchitis. You can see the striated appearance there with a pyocele. This is pus. However, if this was a traumatic event, then this appearance could also be a hematoma, right, or a hematocele. So the history is important here. In the setting of suspected orchitis, this is a pyocele. Okay, so then we'll touch on that last um, inflammatory process that I talked about, where the spermatic cord itself also the entire cord becomes inflamed. And so here's the head of the epididymis here. Here is the spermatic cord above it, which is very hypervascular looking. This is not the same appearance as you would expect from a varicocele, which we'll touch on later. This is inflammation of the entire cord, and the patient usually is in quite a lot of discomfort here. So this is an example of funiculitis of the left spermatic cord. Um, the most dreaded infectious complication, of course, is Fournier's gangrene. This is a medical emergency. It's like flesh-eating disease. So what happens here is that when you're scanning, sometimes you see these pockets of gas within the skin and in the scrotum. So these little echogenic lines, these echogenic bits here with the dirty acoustic shadowing that we see, that is representative of gas, not calcification. Sometimes we think, okay, if it's echogenic, it's calcification, but gas can also have this echogenic appearance. The difference between calcification and gas is that the type of shadowing that gas produces is entirely different. It shows these, like comet tails. It looks like not the same as like calcification, because calcification should cast shadow, so it should be black behind it. You can see this here is not black behind it. It looks very dirty. So this is what we call dirty acoustic shadowing from gas. So this is Fournier's gangrene with gaseous foci in the skin. That's a surgical emergency. So as I mentioned earlier, how do you tell between a funiculitis and varicocele? Well, funiculitis is hyperemia. So it's just increased vascularity, but not distension of the pemmiform venous plexus. So you get the patient to Valsalva. Funiculitis will not change with Valsalva, whereas a varicocele, because you are increasing the intra-abdominal pressures, you're forcing those vessels to dilate. So you will actually see them dilate when you're scanning live. So here's an example of a varicocele here on this left side. And then here is an example of funiculitis. You can see the vessels are quite dilated. If you were just to glance at it, just to look at the color, they look very similar, but they are different because one changes with Valsalva. Okay, we'll move on to scrotal trauma. So usually there's a history of direct trauma to the scrotum. Patient gets acute swelling and pain. So we want to evaluate for the potential complications of testicular rupture, but also to look for vascularity and assess how much of the testis is involved. So the testicular rupture complications, you may remember there was a question about this earlier. So number one, testicular rupture could cause infertility because it disrupts the testis and blood barrier, the testis blood barrier. So it releases the spermatozoa and exposes it to our immune system, which then you can get an autoimmune reaction to spermatozoa and lead to infertility. It can also cause testicular ischemia because the intertesticular pressure increases because there's a large hematoma and causes venous outflow obstruction. So you may end up with an ischemic testis. And then, of course, if you disrupt the vessels, you can create an AV malformation. So all three of these things are possibilities for complications of testicular rupture. So here is a testicular trauma case. There is a testicular fracture here. So there's this line with fluid. You can see it actually kind of comes all the way across to the surface of the testis. And then, the testis itself, the equitexture looks abnormal. So here's a testicular fracture. Earlier, I showed you a pyocele. This is a hematocele following trauma. You see how much they look alike, but again, um, hematomas have a very classic appearance in the initial phases because it is composed of very complex fluid, of course, and as it matures, you start developing these fibrinous strands, and it has these septations in it, and the blood products have variable rates of degradation into more cystic components where it's more fluid, but also semi-solid, clot still. So this is a hematocele surrounding this testis. We don't see a testicular fracture in this case. Okay, here's a very severe testicular rupture. Basically, the entire testis is replaced by this large hematoma. There's maybe little bits of residual intact testis left. This line here, if you follow this line, remember this is your tunica vaginalis and tunica albuginea line, it becomes discontinuous right here and right here. And you can see you see this echo texture matches that. So this is actually a portion of the testis that has extruded and from the disrupted tunica vaginalis layer. So this is a really major testicular rupture. So I don't think this is salvageable. And if you look here, there's no vascular flow in the testis that looks to be intact. This is all hematoma. Okay, so we'll evaluate for scrotal swelling and mass. So the non-traumatic. So it's kind of like real estate in the scrotum. Its location, location, location gives you the differential diagnosis which pathway you want to go down. So the extratesticular lesions, the vast majority, over 95%, are benign lesions. This is also the location that can be involved by TB. So generally, um, there are some exceptions to the extratesticular being benign, and that's often related to extratesticular metastases, or you have these tumors that arise from the extratesticular structures, the liposarcomas, the leiomyosarcomas. So the sarcomatous lesions can arise from the extratesticular structures. Um, those are generally rare. The intratesticular lesion, so if you see a lesion within the testis, the vast majority of those are malignant. They're typically germ cell tumors or sex cord stromal tumors. They're younger patients, in their teens, 20s, 30s. Of the germ cell tumors, half of those are seminomas. The other half are the non-seminomatous germ cell tumors. In the older population, you will see lymphomas, usually non-Hodgkin's, inside the testis, oftentimes bilateral. Okay, so here is an intratesticular mass. So here's the normal left testis. Here is the right testis with this lobulated hypoechoic mass replacing a lot of that testis. It's quite heterogeneous looking. You can see it's not the normal echotexture of the testis. The pathology of this is that it is a mixed germ cell tumor. About 50% of it, sorry, was a seminoma. So you can have different elements even within these germ cell tumors. Okay, another example. So here is normal testis. Here's your mass. Here are satellite lesions. This one contains microcalcification. So this has abnormal internal vascularity. It's lobulated intratesticular mass. 31-year-old male. This was purely seminoma. Okay, so there is one exception um, that we can see in intratesticular that is not malignant, but we would still refer to urology, and that's the epidermoid cyst. So if you know what an epidermoid cyst is it's an invagination of squamous tissue. So imagine if you were to do a cross section of the dermoid cyst, it has this onion ring appearance, and what it is desquamated cells, keratin, and just layers of skin. So you're basically recreating skin, except it's in round form, and it's instead of being on the outside, it's invaginated into the testis. So this onion ring appearance is very classic for an epidermoid cyst. They need to they enucleate this, but it's a benign lesion. Okay, so the extratesticular lesions, 95% of these are benign. The most common cause that I see for referral for a scrotal ultrasound, as far as a scrotal mass is concerned, is an epididymal cyst, or what we call, or a spermatocele. So these are the most common finding. They can become large and multiseptated, sometimes with internal echoes. It displaces the testis rather than surrounding the testis, and many of them arise at the head of the epididymis. Okay, so here's an example. Here's your testis. Here's the simple cyst sitting next to it. Here's the epididymis, right, the head of the epididymis just adjacent here. So this is a simple epididymal cyst, inconsequential. It doesn't turn into cancer. It's not bad. So we can also get hydrocele as a cause for testicular swelling. So remember, there's a potential space between the parietal and visceral layers of the tunica vaginalis. Sometimes that gets filled with fluid. We mentioned why that may have some fluid in the neonatal period, but also at any point in adulthood. So the fluid fills that potential space, and so if you notice, that potential space completely surrounds the testis. So that's how you can tell the difference between a large epididymal cyst versus a hydrocele. So this hydrocele surrounds the testis, right? It goes all the way around almost, except for at the base of the testis, versus this epididymal head or epididymal cyst or spermatocele. It just contacts a small component of the testis and it displaces the testis rather than surrounds it, right? It doesn't go all the way, it's not a circumferential structure. So this is not a hydrocele, but an epididymal cyst. So there's a difference between the two, and that's how I tell between the two. Okay, solid masses. This is a hypoechoic lesion. Here is the right testis. This is sitting outside of the testis in the paratesticular structures. So this ended up being a benign adenomatoid tumor, but we would have to give a differential. So, you know, this has some cystic component. So is this an epididymal cyst with debris? Is this secondary to scrotal TB? Or potentially a supernumerary testis, although the hypoechoic echo texture would argue against this last one. Okay, other causes of scrotal swelling, varicoceles. You can palpate these as a serpiginous, you know, bag of worms in that left hemiscrotum most commonly. So essentially, I've shown you this image earlier. The pampiniform venous plexus gets dilated to over 2.5 millimeters, and you can actually accentuate the size of that by getting the patient to Valsalva, and you can watch those vessels dilate further. So here's another example. You can see these multiple serpiginous tubular structures that just, you know, fill in with color flow. This is a classic, you know, quite prominent hydrocele, varicocele. There are ways of grading these. We won't get into that. That's more for the urologists and radiologists as we describe it. Okay, what is another sign, or one of the other causes of scrotal mass? Of course, is a hernia. So you can get bowel, mental fat, or a combination of both that enters the scrotal sac through adjacent to the cord. So you know, you look for active peristalsis because that is a sign that the bowel is not strangulated. So if you see a dilated but aperistaltic loop of bowel, you are concerned because that can mean strangulation. So I gave there's a little video here that I made of this is the scrotum here, and then there's this mass above it. So you can just watch. So you can see, you know, there's that's the advantage of ultrasound, is that it's a live scan, so you can see this is peristalsing bowel sitting right next to the testis. So this is a huge inguinal hernia. Okay, here's another example. Here's the testis, and then this is omental fat that extends down. So another hernia there. Another example, testis. This is a loop of bowel sitting there with fluid and bowel wall. Okay, we'll do some common findings and then we'll go back to those questions. Okay, so we often see these bright dots inside the testis. They're quite bright. So these are calcifications. So these are what we call testicular microlithiasis. We need to see at least 4 in one imaging plane. There is an association with testicular malignancy, but the association is not a strong one. And usually we just follow these clinically. We don't need to do ultrasound surveillance unless the patient has risk factors like prior testicular malignancy, for example. Typically, though, we don't need to surveil these with additional ultrasound. Just know that they exist and do clinical follow-up more rigorously. Here's a very diffuse testicular microlithiasis. So when we do see this, we want to be very sure that there is no lesion within this field of microcalcifications. So evaluate the testicular parenchyma very carefully. So remember we spoke about the appendix testis earlier. And usually in the setting of a hydrocele, you can sometimes see this calcified, what we call a scrotolith or a scrotal pearl. Sometimes that little outpouching of the tunica will break off and calcify. So this is just a loose body that sits within that potential space under the hydrocele fluid. It can calcify, it's mobile, and it's not concerning and of no further significance clinically. Okay, so let's go back to our questions. So stratal injury, what are the potential complications of a testicular rupture? We spoke about all of those three earlier. You can get infertility, you can get infarcts because of impairment of vascular inflow and outflow, and then of course you can get an arteriovenous malformation, so all of the above. So um, you can get infertility even in the setting of a single testis being ruptured because of the formation of those sperm autoantibodies. Okay, this one is a tough one. I showed you a lesion here, and I said, okay, this lesion is most likely malignant. So this is false, because if you look here, here is the testis. If you look carefully, this is the line of the tunica, and this lesion is sitting on top of the testis. There's actually, it splits off from the testis, so it's not within the testis, but adjacent to the testis. So this is an extratesticular lesion, probably an adenomatoid tumor, as we mentioned before. So, okay, here is a 4-year-old male with painless scrotal swelling. This is a large hydrocele. Remember, we talked about how it surrounds. So this is a testis in a 4-year-old. So you can see how challenging it can be to try to find, in the normal setting, to try to find vascularity inside this tiny structure. So this is a hydrocele that surrounds the testis, goes all the way around. So that's a hydrocele, and it's not a varicocele, it's not a scrotal cystic mass, and it's not an epididymal head cyst, because remember, it doesn't displace the testis, it surrounds the testis. Okay, this one was tough. This is, an example of a diffuse, extensive microlithiasis. However, the echotexture of the testis is abnormal. It's not that gray color. It's quite dark. So all of this is seminoma, and there is testicular microlithiasis. So some of it has also been pushed to the edge because of this lesion here, right? So this is microlithiasis, and this is all seminoma. Okay. Any questions?
Hello.
Hi,
Yes, thanks, Doc, for the presentation.
you're welcome.
Yeah, I just have one question. In the Sorry if I didn't get it right during the presentation, but in the setting of a traumatic event, if I'm to do an ultrasound of the testes, what are some basic things that I should be like looking out for in the setting of trauma?
What are you looking for in the setting of trauma?
Yeah, like if somebody come with testicular pain, with history of trauma, and I'm to do an ultrasound, maybe, yeah.
Yeah, so
Yes. Yeah.
what you want to do is you want to scan the testis and look for any of those, linear bands or of a testicular rupture, for example, within the testis. You're looking for areas of altered echogenicity that would potentially represent, um, a testicular rupture. So we'll go back here. So here, right, you're trying to look for alteration in the echo texture. You can see these like lines here. This is a testicular fracture. In this patient, this is a big hematoma here. Inside the testis, you look for hematocele formation, so blood around the testis. But yeah, you're looking basically for these fractures within the testis and then hematoma. And then if you do see those things, then you want to evaluate whatever you see of testicular tissue. You want to make sure that there's actual blood flow that's still maintained in that area, because you want to exclude foci that are ischemic. Um, and if there is ischemia, these are not salvageable, and they end up getting an orchiectomy. If on the other hand, you see just a big hematocele, but there's good blood supply, and then you don't see a testicular fracture per se, then you probably will end up just watching these patients, right, to ensure that the hematocele resolves. So those are the things that you're looking for, and you're looking for those complications. In the later stages, if the trauma was not as recent and you see something like this, then what you want to do is you put color on everything to make sure there isn't an arteriovenous malformation that has developed inside that testis.
Hello, Brian.
Hi.
Yeah, yes. Thank you for the presentation. I was really happy to have free time and follow it. Yeah, I have that question about you talked about this zebra-like structure in orchitis, and
Yes.
then in trauma also we can have one when there is this fracture. How will we make the difference between those two?
The history.
The history.
Yeah,
Good.
the history will be crucial. They both represent the same thing, though. It's basically they represent fluid that is outlined the testicular stroma. So there is a slight difference between testicular edema from orchitis versus this fracture, right? Because this doesn't follow any particular line. It disrupts um, the normal architecture of the testis versus an orchitis, which it looks more confined to the septae. So I know here you may say, okay, well, how is this different from this one? But this one is bizarre. There are branches, and it looks jagged and irregular. This one almost looks like it makes a rounded corner in this individual structure, whereas here, where did I go? Skipped it. This has a more linear appearance. It extends to the outer margin, and then it goes inwards, and it's almost like more straight lines. I know this is not a great example, but um, let's see if I have another one. Again here, it shows these linear lines that outline the fibrous septae. It's a different appearance of those zebra lines. But the biggest thing I would say is that the history will
The
will
history.
give you the way to determine between those two.
Yes, and I like the idea of infertility post trauma, because at the beginning I was like, okay, what will happen? But actually, I understand that with the autoimmune process, it is easy. I like that idea really, because I was like, if we have one testis, then the patient can still maybe, but I was happy that you underlined it very well, that it is from the autoimmune process. I
Yes.
learned. Thank
Yes.
you.
So like in the long run, the autoimmune process can cause infertility. At initially that process takes time to develop, right? But who knows at which point. But yes, that even one testis affected can cause infertility. So perhaps that is if you encounter a patient in the future with infertility issues, that may be part of the history that you can take. Was there a history of scrotal trauma in the past? Because that can certainly cause that issue.
Thank you, really.
You're welcome.
Okay.
I'll share the slides with Omega, and then he can share those with you as well.